This is my second video on the topic insulin and oral anti-diabetic drug. So in the first video, I told about how the insulin it is synthesized, how it is secreted or released, what is the mechanism of its secretion, and what are the factors which are going to affect its secretion and the deficiency of the insulin that leads to diabetes mellitus. Then what are the types of diabetes mellitus and ultimately the treatment. We started with this treatment part of the diabetes mellitus. So how we are going to treat the diabetes mellitus? So anti-diabetic medication or drugs. What are the various drugs? So how we can classify anti-diabetic drugs? We classify depending on its mechanism of action. The first one, the drug which are going to act by increasing the level of insulin. They are also called insulin secretagogue. So in this we further classify into parenteral and oral. So this whole thing, oral and parenteral, this I covered in my previous video. If you haven't watched that video, I will be giving a link in the description box. You can go and watch it, that video also. And now the second group of drug, that is which is going to act by overcoming the insulin resistance. So under that, what all drugs comes? So drugs which act by overcoming insulin resistance. So we have under this two group of drugs are there. One is Biguanides and other one is Thiazolidindiones derivative. So with the Biguanides, we have two drugs, they are there, Metformin and another one is Metformin. But clinically we use only Metformin. This is not used. Now how Biguanides or Metformin, how this group of drug they act? What is the mechanism of action of this group of drug? So mechanism of action of Metformin. So how they are going to act? They are going to act by overcoming the insulin resistance. So they are AMPK agonist. So Biguanide or Metformin, they are AMPK agonist. That is AMPK stands for kinase. So wherever this word come kinase, that means we are talking about the phosphorylation of the enzyme. Now with the phosphorylation, it is going to do what? There will be inactivation of the enzyme and there will be activation of the. So phosphorylation causes the activation of the certain enzyme and inactivation of the certain enzyme. Now activation of which type of enzyme it is going to cause? So it is going to cause the activation of those enzyme which is going to cause the utilization of the glucose. ठीक है, जहाँ पे यूटिलाइजेशन होगी ग्लूकोज की, सो दैट ग्लूकोज लेवल इज डिक्रीज्ड, utilization of the glucose or it get deposited, and inactivation of the enzyme which is going to cause the production of the glucose, like gluconeogenesis, hepatic gluconeogenesis, whatever the enzyme they are involved in the hepatic gluconeogenesis, it is going to cause the inactivation of those enzyme. So with this activation and inactivation, so what it is ultimately going to do, it is going to cause the number one, अगर मैं inactivation की बात करती हूँ, it is going to suppress the hepatic gluconeogenesis. Then another one, what else in the liver? But what are the other way it is going to decrease the level of the blood glucose? By suppressing the glycogenolysis, both in the liver and even in the muscles. So it is going to inhibit the glycogenolysis. So you can see here, so it is going to inhibit this. And what else it is going to, how it is going to increase the utilization? By promoting the glycolysis. So glycolysis kaise? It is going to activate the enzyme which is going to increase the uptake of the glucose, especially in the muscle cell and adipose tissue, and that glucose uptake ultimately it will be utilized where? In glycolysis. It undergo the glycolysis. And another one is, it is also going to increase the glycogenesis. So you can see here in this figure also. So this is this I have drawn the blood vessels. Blood vessels I have drawn, and with this with lighter color. So this is the blood vessels, and here the blood glucose that is shown. So what it is, this metformin, it is going to decrease this blood glucose level. How it is going to decrease the blood glucose level? By inhibiting these two, gluconeogenesis, so suppressing the hepatic gluconeogenesis and glycogenolysis, and here also glycogenolysis. This I have told. Then by promoting the uptake of this glucose, कहाँ पे uptake होगी? With the muscle and adipose tissue, and this will undergo glycolysis, and it also promote glycogenesis. Then another is, it is also going to inhibit the intestinal absorption of glucose. From the intestine, the blood glucose, that absorption, it is inhibited. So how it is going to act? Number one, suppressing the hepatic gluconeogenesis. This is the number one. So it increases the inhibit the glycogenolysis. Then third one is reuptake of or uptake of the glucose in the muscle and adipose tissue and promote the glycolysis and glycogenesis. And the fourth one is, it is going to retard or inhibit the intestinal absorption of the glucose. So by this way, it is going to decrease the blood glucose level. Remember one thing here. So this drug, it is not anyway, it is not going to cause the release of insulin from the pancreatic beta cell. So it is not an insulin secretagogue. Now, how we are going to take this drug? This drug, we take it by oral route. It is taken, they say it is taken along with the meal. आप चाहे खाने से पहले ले लो, खाना खाने के बाद ले लो, you can take in between the meal. So oral absorptions, it is with the duration of action, that is 6 to 10 hours. So it is metabolized in the liver and excreted in the kidney. What are the important adverse effect of this drug? So it inhibits the absorption of glucose from the intestine. So it, along with that, it is going to inhibit the absorption of many other things. So one of the important thing it is going to inhibit the absorption, that is vitamin B12. So it is going to cause the deficiency of the vitamin B12, that leads to megaloblastic anemia. So M for metformin, M for megaloblastic anemia. So remember one thing, megaloblastic anemia. What is the cause of megaloblastic anemia here? It is a deficiency of vitamin B12. Similarly, agar phenytoin hai, which is important anti-epileptic drug, so that the deficiency of that also leads to the megaloblastic anemia, phenytoin, but there it is due to the deficiency of the folic acid. So this is number 1. Another one is various GIT symptoms like pain, abdomen will be there, nausea, bloating, even mild diarrhea. Patient may have a mild diarrhea. But all these will be alright after some time. This will be the temporary. इसलिए इसको हम ज़्यादा these GIT symptoms, they are just temporary for a short time. But this will be there, so you have to put the patient on vitamin B12. What are the other important side effect? That is a lactic acidosis. So lactic acidosis, this is very common with the fenformin and not very common with the metformin. Because of this drug, it was banned. But with the metformin, only in certain situation, it can lead to lactic acidosis. When it can, metformin में कब होगा lactic acidosis? Metformin in certain situation. What are those? If there is a renal insufficiency. If there is a renal insufficiency, there is a hepatic disease, there is a pulmonary disease, there is a hypotension, there is any shock or any hypoxia. So under this situation, even metformin, that can also lead to lactic acidosis. Now why it is going to produce a lactic acidosis with this? See, with the glycolysis, one of the important is it is going to cause the utilization, uptake of the glucose, and it get utilized. Utilization how? With the glycolysis. And the end product of the glycolysis, if anaerobic, that is a lactic acidosis. Normally this level it is less with the metformin. Utna banta hai, so it will be cleared. It will be metabolized. Normally it is metabolized by liver or excreted by kidney. But if there is any hepatic disease, agar patient ko koi hepatic disease hai, then what will happen? That metabolism will not happen. Or if it is suppose more, how this lactate, it will undergo hepatic gluconeogenesis. So this drug, it inhibit that also. So it is not metabolized, it does not undergo hepatic gluconeogenesis. So if the person is suffering with the hepatic disease, then metformin should not be given. Then with the renal insufficiency, now lactic acid, whatever is produced, it won't be excreted. So level will be increased. Similarly, in pulmonary disease or in hypoxia, then what will happen? There will be anaerobic glycolysis. So that leads to lactic acidosis. So metformin, it is contraindicated. All these are the contraindication of metformin. Why they are the contraindication of metformin? Because they are going to cause the lactic acidosis. So these are the adverse effect as well as the contraindication of the. So remember one thing, vitamin B12 deficiency and lactic acidosis, they are the important adverse effect of the adverse effect of the metformin, and these are the important contraindication of metformin. So contraindication already I have told. Now where we are going to use, this is the first choice drug for all the type 2 diabetes mellitus until and unless there is any contraindication. Now why it is a first choice? Why metformin? It is a drug of choice for type 2 diabetes mellitus. So there are the this is also very commonly asked. So why it is a metformin? It is a drug of choice. Number one, it is not a hypoglycemic. It is a anti-hyper. So just like with the sulfonylurea group of drug, they are a hypoglycemic. Then efficacy. It is efficacious. Efficacy is good. It is going to cause a reduction of HbA1c by 0.8 to 1.2%. Then it is going to take care of both microvascular as well as macrovascular complication. It is going to reverse that. Number 4, it is going to inhibit the beta cell failure. It is going to take care of the health of beta cell and inhibits its failure. It can be combined with any other anti-diabetic drug. So इसको आप किसी के साथ भी you can combine it with any other drug. So that's why the metformin, it is a drug of choice for type 2. At least remember, try to remember all this. It is not a, it is anti-hyperglycemic, good efficacy, take care of, reverses both micro and macrovascular complication. It is going to inhibit the beta cell failure, and we can combine this with any other anti-diabetic medication. So that's why it is a first drug of choice for the type 2 diabetes mellitus. So we can combine it. You can see next sulfonylurea, meglitinide, glitazones. Okay. So another use is in infertility. Infertility because of the PCOD, polycystic ovarian syndrome. It is going to enhance the fertility in the women by enhancing the insulin sensitivity. So this is about the metformin or biguanides. So another group of drug which act by reversing the resistance or increase the insulin resistance, that is thiazolidindiones or glitazones. इसको हम क्या बोलते हैं? We say it glitazones. So we have troglitazone, rosiglitazone, pioglitazone. So clinically we use only pioglitazone. Now what are this group of drug? They are PPAR gamma agonist. What is this PPAR? They are peroxisome proliferator, peroxisome proliferator activated receptor gamma agonist. And what are these receptors? They are the nuclear receptor which are going to take care of the transcription of various genes. And here which genes they are going to? Insulin responsive gene, which are going to take care of both glucose metabolism as well as it is going to take care of fat metabolism. So we have three type of this one PPAR, PPAR alpha, beta and gamma. Now we are talking about pancreas. So this is present one side. Tell you this is present in the pancreas. This is alpha. Alpha, if I write it at A, so remember it with the adipose tissue. Beta, beta stands with the B. Remember it with the brain, and gamma with the both pancreas and adipose tissue. Now, how this group of drug they are going to act? So they are PPAR gamma agonist with the slight activity of PPAR alpha. So these drugs, they are agonists of nuclear peroxisome proliferative activated receptor gamma, which is going to enhance the transcription of several insulin responsive genes which control both glucose and lipid metabolism. Now, how with the glucose metabolism? With the glucose metabolism, number one, they inhibit gluconeogenesis. Number two, they are going to reverse the resistance by stimulating this glucose transporter 4. Remember, glucose transporter, I told you there are many, but remember 2 and 4. So 2 is present in the pancreas, beta cell of the pancreas and liver, and 4, remember, it is present in the muscle and adipose tissue. So it is going to enhance the expression of this where on the muscle and fat tissue. So what will happen? The entry of the glucose and the muscle and fat will be enhanced. So another one is, so this is about the glucose metabolism. Then with the fat, gene regulating the fatty acid metabolism and lipogenesis in the adipose tissue, they also contribute to the insulin sensitizing action. Then they have pioglitazone, have alpha activity also. So they are going to lower this triglyceride level and raise the HDL level. The rosiglitazone, but pioglitazone, no change in LDL. LDL का level कौन? Rosiglitazone, that is going to raise the LDL cholesterol. So that's why it is side effect is myocardial infarction. Because of this side effect in most of the country, this drug, it was banned in 2010. So pioglitazone, so I told you already, pioglitazone is the only thiazolidindiones which is used clinically right now. So we give it by oral route and it is metabolized by 3A4 and 2C8. Now, what are the important adverse effects with thiazolidinedione derivative? The most important is weight gain. Weight gain is because of what? So weight gain is because of the fluid retention. So avoid this drug if the person is having congestive heart failure or hypertension. So another is fluid retention. There it causes macular edema. So weight gain aa gaya iska. Then hepatic dysfunction. Hepatic dysfunction, that is seen with all the three. Troglitazone, then rosiglitazone, and then another one is pioglitazone. But maximum it is seen with the troglitazone. So because of that, hepatotoxicity, it causes the hepatotoxicity. Because of that, the troglitazone, that is banned. Whereas if you are going to put the patient on pioglitazone, go for LFT, because then all of them, they are going to cause the fracture. So predisposed to osteoporotic fracture. With the rosiglitazone, already I have told, there is an increased risk of myocardial infarction. That's why this drug, it is banned. And with pioglitazone also, it was banned in 2013 even in our country because of the risk of urinary bladder carcinoma. But later on they have cleared this doubt. They say the urinary bladder carcinoma, it happens only in the person who shows the risk factor. So that's why they have again marketed this drug, but with a label not to be used as a first line drug. So this is drug used in mild cases. Second one is as an add-on drug. So where we are going to use this drug, so these are the contraindications. So hepatotoxic hai, so we have to go for the LFT. Fluid retention, CHF, it is going to, then osteoporosis, fracture है इसका, myocardial infarction है, urinary bladder carcinoma. Okay, so all these are the adverse effect keep this thing in the adverse effect of thiazolidindiones, that is very, very important. So these are the important contraindication: hepatic disease, congestive heart failure, pregnancy, lactation, and in children. Now where we are going to use this drug, so as a monotherapy in diet and exercise only in mild cases. But nowadays they say even not to be, but it is marketed as not to be used as a first line drug. Then usually supplement with the metformin or sulfonylurea, and it is going to reverse the insulin resistance and also delay the progression of pre-diabetic to overt type 2 diabetes mellitus. So two drugs which is going to delay the progression of pre-diabetic to overt type 2 diabetes. One is metformin. They are also reversing the insulin resistance, and this drug, it is also what it is going to reverse the insulin resistance. That is the main pathogenesis of type 2 diabetes mellitus. So this finishes the second group of the drug which act by overcoming the insulin resistance. Now coming to the third group of drug, third is which is going to decrease the glucose absorption. So where it is going to decrease the glucose absorption in the intestine. So with that, the group of drug, that is alpha glucosidase inhibitor. So what all drug we have here in this group? We have Acarbose, we have Voglibose, and we have Miglitol, all the three. So all the three, they are alpha glucosidase inhibitor. Now this alpha glucosidase inhibitor, how they are going to act? So first you must know what is the action of this alpha glucosidase. So alpha glucosidase, this is the enzyme which is present in the brush border of the intestine. So this is the intestine. This is the lumen of intestine, and here, so here alpha glucosidase, they are present. So this helps in what? It is going to break down that bigger particle of whatever you have taken the food into a small particle and helps in the absorption, reabsorption in the intestine. This is the action of alpha glucosidase. If you are going to inhibit this by giving the inhibitor, then what will happen? The absorption of this is inhibited. Okay? So this is going to inhibit the absorption. Now where this bigger particle or polysaccharide will go, it will remain within the intestine, and intestine में इसकी क्या होगी? Cause the fermentation, and this is going to do what? It is going to cause the flatulence and loose stool. So these are the annoying adverse effect of the alpha glucosidase. So because of that, the people, they do not prefer this. So this drug, it is also used as an add-on drug. It is a mild anti-hyperglycemic. इसका जो है HbA1c, it is going to reduce the HbA1c to 0.4 to maximum 0.6 or 0.8%. That's it. So these are the important side effects with this GIT side effect that are seen, and that is seen because of this. Now another group of drug, that is SGLT2 inhibitor, that is sodium glucose co-transport 2 inhibitor. Now here we have एक मैंने अभी पीछे glitazones, ये क्या है? They are gliflozin. So don't get confused. They are canagliflozin, dapagliflozin, sergliflozin, and remogliflozin. So out of these canagliflozin and dapagliflozin, what are they? They are the SGLT2 inhibitor. This is a newer drug. So what is how this group of drug they are going to act? So where they are present, SGLT2. So normally what happens? In the nephron, the glucose that is filtered and this glucose in the PCT, normally the 100% of the glucose that get reabsorbed with the help of what? With the help of SGLT2. Now if you are going to give canagliflozin, then what will happen? This is going to inhibit this SGL. It is going to inhibit this SGLT2. Then what will happen? This reabsorption of the glucose, it will not happen. Moreover, now because of in a diabetic patient, the glucose which is filtered, the amount is more. So all this, if the glucose, it is not reabsorbed, then where it will go? It will go into the urine, or ultimately it leads to glycosuria. So along with glycosuria, there will be loss of sodium. So ultimately, what will be the side effect of this drug? Now glucose that is excreted round the clock, the glucose, it get excreted with the urine. So person is prone for UTI, urinary tract infection. So there is an electrolyte imbalance with this. So these are the important adverse effect with the SGLT2 inhibitor or canagliflozin, dapagliflozin. So this drug, it is also used as an add-on drug with the metformin. So nowadays they say this drug, even it is approved for, we can use this one even for the CHF. Then another group of drug, the new one, that is a bromocriptine. What is a bromocriptine? Bromocriptine, it is a D2 receptor agonist. Now how this group of drug, they are going to help in diabetes mellitus? They reverse they take care of the insulin resistance. So one cause of insulin resistance in diabetes mellitus, what they say, there is a balance between dopaminergic activity and sympathetic activity. Now, if we give, and what happens usually in diabetes, there is this decrease in dopaminergic activity and increase in sympathetic activity, and this leads to insulin resistance, and this happens usually in the early morning. So if you give dopamine agonist, अगर हम यहाँ पे dopamine agonist दे देते हैं, they are going to reverse this decrease in the level. Bromocriptine, अगर if I give bromocriptine, that to early morning, this is going to reverse this decrease in the level imbalance, and ultimately it is going to reverse this insulin resistance. This is how the bromocriptine, it is going to help in the type 2 diabetes mellitus. And few other newer drug, that is pramlintide, which is a amylin analog. Then we have a colesevelam, and another one is a epolrestat. So these are the three newer drugs. Now pramlintide, it is an amylin analog. If you remember, with the in the beta cell, along with the insulin, the amylin, it is also secreted. So this is going to decrease the blood glucose level, and this is the only, pramlintide is the only drug which has got FDA approval for the use even in type 1 diabetes mellitus. Because of that, this drug, it is right now, it is one of the important short note. So pramlintide, it is approved. This is, there are many other we use it, but FDA approval has been given only to this drug. So apart from the insulin, we can use pramlintide and for the type 1 diabetes mellitus, and this is given by subcutaneous route. And how this group of drug they act by suppressing the glucagon release, delays the gastric emptying, CNS mediated anorectic effect, suppresses the appetite, and it may improve the LDL and HDL profile. So you can see here it is used for both type 1 and type 2 diabetes mellitus. We give it by subcutaneous route half an hour before the meal, and we start with 15 microgram, increase up to 30 or 60, and decrease the dose of insulin to 50%. Half-life is 50 minutes, duration of action is 3 to 4 hours, and do not mix this one with the insulin in the same syringe. And these are the adverse effect of the pramlintide. Next we have a cholecalciferol. Cholecalciferol, it is a bile acid binding resin. So it is going to decrease both the fat as well as a glucose level, because it's a bile acid binding resin. Next one is a epolrestat. Now, how epolrestat it is going to act? It is a aldose reductase inhibitor. Now, what is the action of this aldose reductase? Aldose reductase, what it is going to do in diabetic patient, the glucose, because there is a huge amount of the glucose that is there. So this gets converted into sorbitol with the help of this enzyme aldose reductase, and this sorbitol, it gets accumulated where? In the nerves, and it leads to diabetic neuropathy. Now, epolrestat, it is going to inhibit this drug. It is going to inhibit this drug. So sorbitol formation, that is inhibited. It won't get accumulated, and it is going to delay the diabetic neuropathy. So that's all about the anti-diabetic drug. Now, how we treat the patient. So you can see just a look of all the anti-diabetic drug which I have covered, or what are all the anti-diabetic drug we can use for a patient. So here it is, this again I have taken it from the standard textbook of pharmacology, that is KD Tripathi. So here the word oral anti-diabetic, because it is not this classification, it is not covering the exenatide GLP analog, because that is the one which is we give by abhitak GLP, that we give by subcutaneous route. Then another one is pramlintide, that is also not covered with this, because that also we give by subcutaneous route. That's why it is written oral. If you are writing that drug also under the classification, then omit this word oral. Okay? So classification of the anti-diabetic drug, that is very important. And remember, if they have asked oral anti-diabetic, then don't write GLP-1 analog and pramlintide. Okay? So oral anti-diabetic drug, depending on the mechanism of action, they act by enhancing the insulin release. So insulin release में आपका, you can see here already I have covered oral में, ठीक है? ATP sensitive potassium channel blocker, we have 2, sulfonylurea meglitidenide and DPP4 inhibitor. Then here what we have, these are oral, and then we have a parenteral also, that is GLP-1 analog. So under that we have exenatide and liraglutide. Then the drug which act by overcoming the insulin resistance, this we have biguanide and thiazolidindiones. So biguanide, that is AMPK activator, and this is PPAR activator. Written the only drug which we use clinically, metformin under this, and pioglitazones. Another one is which is going to retard the carbohydrate absorption, alpha glucosidase inhibitor. Then miscellaneous drug, under that we have SGLT inhibitor and dopamine agonist, that is bromocriptine. So what is under the miscellaneous drug? What is left? One is pramlintide or amylin analog. Then colesevelam. Then we have epolry, epolry stat. Okay, so this is all about the anti-diabetic drug. Now, if any patient is diagnosed with the type 1 diabetes or type 2, how we are going to write this drug, how we go about that. So this, any patient with the diagnosed with the type with the diabetes, if it is a type 1, diet and insulin. If it is controlled, it's okay. What is the other drug we can use for the type 1? That is pramlintide. So any patient with the diagnosis with the type 2 diabetes mellitus, already I have told, which is a drug of choice, metformin, until unless there is a contraindication. So why metformin? It is a drug of choice in type 2 diabetes. This I have covered. And what are the contraindication? If there is any renal insufficiency, hepatic disease, pulmonary disease, hypertension, okay, then don't write the patient metformin. So if it is controlled, it is okay. If it is not controlled, if it is uncontrolled, then this is the number 1 drug, main drug. So then we have to add the second drug. So second, sulfonylurea. So metformin आपकी चलेगी. Sulfonylurea, it is a preferred second line drug. Okay? Or you can put the patient on meglitinide, pioglitazone, newer drug, DPP4 inhibitor or alpha glucosidase. But this one is a preferred drug. And again, if it is a controlled, it is all right. And if it is not controlled, then what? You have to add 2 drugs. Apart from metformin अभी चल रही patient की, ठीक है? So metformin only until unless the patient end up with some renal complications. Suppose any diabetic patient taking the metformin, but now patient is having some renal problem, then you have to withdraw that drug and write some other drug to the patient. So 2 drug. What are the 2 drug? The third drug which is preferred, that is a thiazolidindiones, that is pioglitazone. So if it is controlled, it is all right. If it is uncontrolled, then ultimately we have to put the patient on insulin along with the metformin, along with this sulfonylurea, and okay. So ultimately, and if any time the patient is having during pregnancy, infection and surgery, then we have to put the patient on insulin and metformin. So whether the patient is with the type 1 or type 2, so ultimately we have to put the patient on. If it is not controlled, what we have to give? We have to give the insulin. So this I will be covering in the next video about the insulin. So if you have any query in today's video, so you can ask in the comment box.